Hello and welcome everyone to Journal Club with Authors, number 12, here on Oral Pathology 360. I'm Dr. Mandana Donahue and I am so glad you could join us today. What I love about this series is that it gives us the chance to hear directly from the people behind the research. Before we get started, just a few housekeeping notes. If you are watching from anywhere other than YouTube, come join us on YouTube so you can interact with us through the live chat. For a clearer picture, tap the settings gear and switch to 720p or higher. Certificates are available for channel members who attend the live stream and fill out the certificate request form. You'll find the link in our community posts, and if you're not a member, you can join anytime by clicking the join wheel, the join button, which is just below the video. And of course, let us also take a moment to welcome our new members, Nandavanshi and Sakshi Janbade. And another little quick update before we move on. On October 25th, we have a faculty development webinar on recognizing early signs of depression and suicidal ideation in students. It's a very important topic, and I do hope many of you will be part of that conversation too. With that, let's get started. I'll now hand it over to Dr. Pouyan Aminishakib, program chair for this series, and of course the host for the session. So welcome to Journal Club with Authors.
Hello, Dr. Mandana. Thank you very much for your nice introduction. And hello, all participants, and welcome to the 12th Interactive Online Journal Club organized by Oral Pathology 360. It's a great honor for me to welcome and introduce our distinguished guests, Professor Dr. Abbas Agaimy, to this online journal club. Professor Agaimy is a leading figure in diagnostic pathology and currently serving as professor and the deputy director at the Institute of Pathology, Friedrich Alexander University, Erlangen-Nürnberg in Germany. Professor Agaimy earned his medical degree from University of Khartoum and later requalified at the University of Freiburg, Germany. He completed his pathology residencies across major German clinics and received board certification in anatomic pathology from the Bavarian Medical Council in 2004. Over the past years, he has become internationally recognized for his expertise in tumor pathology, particularly soft tissue, endocrine, and gastrointestinal neoplasms, and also head and neck tumors. His prolific academic output includes hundreds of peer-reviewed publications, and he has been consistently ranked among the top 2% most cited scientists globally in pathology for 2022 and 2023 and 2024. Thank you very much, Professor Abbas Agaimy, for accepting my invitation.
Thank you very much. My pleasure.
Welcome. And it's a great pleasure for us to have Dr. Suma. She is Associate Professor at Department of Oral and Maxillofacial Pathology, DA Pandu Memorial RV, Dental College, Bengaluru, Karnataka in India. Thank you very much, Dr. Suma, for accepting our invitation and supervising our talented, enthusiastic residents.
Hello, good afternoon, everyone, and thank you so much, sir. It is indeed an honor to be on the other side of the screen today. Thank you so much, Mandana ma'am and Pouyan sir, and Professor Abbas Agaimy sir.
You're welcome. And also, it's a pleasure for us to have Dr. Yashwanat as a resident in this program. He's from DA Pandu Memorial RV Dental College, Bengaluru, Karnataka, from India. Thank you, doctor, for being with us. And we are looking forward to watching your presentations.
Good afternoon, everyone. It's my pleasure, sir, and my privilege to be here with great esteemed faculty members. Definitely, I would like, it would be a very great presentation.
It should be. And the title of our article is the FGFR3 TACC fusions in head and neck carcinoma, a study of 9 cases highlighting phenotypic heterogeneity, frequent HPV association, and a morphologically distinct subset in favor of a putative entity. A great topic, and we are all looking forward to watching the presentations, the first presentation. Dr. Mandana, we are all ears.
Yes, here is the first presentation. Let's listen and then we'll be back for the discussion.
Thank you.
Good afternoon to all the respected dignitaries and esteemed faculty members present here. Today it's my privilege to present international journal article published by the Virtuos Archive titled as Fibroblast Growth Factor Receptor 3 and Transformed Acetic Coiled Coil 3 Fusions in Head and Neck Carcinomas. A study of 9 cases highlighting phenotypic heterogeneity, frequent HPV association, and a morphologically distinct subset in favor of a putative entity. These are the table of contents for today's presentation. To begin with, head and neck carcinomas are diverse group of malignancies with etiological factors such as alcohol, tobacco, and human papilloma virus. With the recent advances in the molecular pathology, gene fusions play an important role in development of tumors. They do not play a significant role biologically, but act as diagnostic markers and therapeutic agents. Among such gene fusions, FGFR genes are involved in the current study, which are found on different chromosomes and involved in gene fusions across multiple cancers in different organs. They are targetable by therapy and act as resistance mechanisms in patients with epidermal growth factor receptor targeted tyrosine kinase inhibitors. As this gene fusion is rare overall, but it is the most frequent type of tyrosine kinase fusion, which is most commonly seen in urothelial carcinoma approximately with 12% and also seen in head and neck squamous cell carcinoma with approximate of 3.7%. Unlike many other fusion-driven neoplasms, phenotype-genotype correlations for FGFR3 TACC3 fusions in head and neck carcinomas are still unclear. Thus, the primary aim of the study was to describe clinicopathological spectrum of FGFR3 TACC3 fusion in positive head and neck carcinomas and also to explore whether this fusion defines a distinct morphological entity or it is a random event. Moving on to the methodology, cases were initially screened for gene fusion due to their confusing morphology, and additional cases were then searched in the molecular database of the institutions. None of these cases were reported earlier. In the present study, 9 fusion positive cases were identified and retrieved from the origin of sinonasal tract, salivary glands, oropharynx, and larynx. To detect the type of gene fusions, next generation sequencing and HPV testing was done, and the clinical follow-up for the above cases was done between 9 to 21 months. Further, the HPV testing was done by in situ hybridization, DNA-based method, and real-time PCR assay. Summarizing the findings of the present study, the results showed 9 patients with 6 males and 3 females aged 38 to 89 years of involving sinonasal tract of 4 cases and 2 cases of parotid gland and each one of submandibular gland, oropharynx, and larynx. And the clinical outcome showed 4 patients with local recurrence or metastasis, and 2 patients died of disease, and 1 patient died of unrelated cause, and 2 were disease-free at follow-up. This is the tabular representation of above 9 cases, including demographic data, histological pattern, treatment, outcome, and type of gene fusion. Under the pathological findings, the initial diagnosis for the above 9 cases was given by the pathologist as follows. Under pathological findings, the tumors were segregated into 3 main categories, of which first was unclassified HPV negative with distinct non-SCC morphology, and the second was HPV associated group with heterogeneous morphologies, and the third was conventional squamous cell carcinoma. The first category was unclassified head and neck carcinoma involving 3 cases, of which all were HPV negative. The tumors were composed of diffuse sheets and confluent nests of medium-sized epithelial cells which were basophilic to pale eosinophilic. They resembled to squamous epithelium but lacked clear squamous features such as intercellular bridges, prominent cytoplasmic eosinophilia, and keratinization. They also showed mixed inflammatory reaction with inflammatory patterns similar to sinonasal DEK-AFF2 carcinomas and monomorphic mucoepidermoid carcinoma. And one case under this category, which was a recurrent tumor, showed abundant cytoplasmic mucin, which was Alcian positive, closely mimicking mucin-rich mucoepidermoid carcinoma. The mucinous area was only focally present in the primary tumor. The other case was laryngeal tumor, which showed features of transitional cell-like syncytial growth resembling inverted or endophytic solid papilloma. It also showed prominent lymphoid reaction at the tumor-stroma interface. The initial diagnosis for these cases was given as inverted papilloma-like lesion, and the final diagnosis was variant of mucoepidermoid carcinoma. These are the photomicrographs of the unclassified head and neck carcinoma cases where A, B, and C depicted transitional-like cell morphology with prominent neutrophilic inflammation, whereas D and E showed laryngeal tumor, which was a variant of mucoepidermoid carcinoma. The second category under pathological findings was HPV-associated carcinomas involving 3 cases of sinonasal tumors. The first tumor showed adenoid cystic-like morphology with transitional-like epithelial areas, which was diagnosed as multiphenotypic sinonasal carcinoma and was positive for HPV33. And the second tumor showed non-intestinal glandular growth with high-grade features, an abrupt transition to a solid undifferentiated tumor component, which was positive for HPV18. And the third tumor showed features of mucinous adenocarcinoma and also showed the presence of high-risk HPV infection in which the subtype was not determined. These are the photomicrographs for HPV-associated carcinoma category where A and B show multiphenotypic sinonasal carcinoma and C shows immunohistochemical positivity for HPV33 and where E and F depict mucinous features. And one case under this category involving submandibular salivary gland showed similar features to the sinonasal tumors but had larger epithelioid cells. It also showed prominent mononuclear inflammatory background and the central area showing sclerosis and hyalinization. The features were similar to salivary duct carcinoma. On immunohistochemical staining was positive for AR and GATA3 and negative for P40, and this was HPV negative. These are the photomicrographs of areas A and B showing submandibular salivary gland tumor which resembled HPV-associated carcinoma and was initially diagnosed as salivary duct carcinoma ex pleomorphic adenoma. The third category was conventional squamous cell carcinomas, which involved 2 cases of parotid gland and oropharynx. This showed features of typical keratinizing squamous cell carcinoma and a variable keratinization typical of squamous cell carcinoma. These are the photomicrographs where C and D show the features of conventional squamous cell carcinomas. Based on the immunohistochemical findings, all cases except case 5 showed squamous immunophenotype and diffuse pankeratin, which was positive for CK5, CK6, P63, and P40. And case 5 was positive for AR and GATA3 and negative for P40. And case 9, which was an unclassified sinonasal mucinous adenocarcinoma, showed positive for CK7, NKX3.1, and negative for the following markers. Case 1 and Case 6 showed strong diffuse membranous staining for FGFR3. Under the molecular findings, HPV testing for 7 tumors showed in association with HPV33N multiphenotypic carcinoma and HPV18 association in mixed adenocarcinoma and HPV33 in unclassified mucinous adenocarcinoma. P16 was a block type positive in 2 HPV positive cases and negative in most of HPV negative cases. And the unclassified squamous tumors of 3 cases were all HPV negative. This FGFR3 TACC3 fusion was present in all the cases with different breakpoints, in which case 5 showed additional gene fusion and TP53 mutation, and case 9 showed additional RPS6KB1 VMP1 fusion and amplifications of CDK4, GLI1, MDM2, and ORCA.
Great presentation. Thank you, Dr. Yashwant. Before getting started, the first discussion session, I would like to invite all audience participants to join this program, Interactive Online Journal Club. We will invite other authors, and we will provide a bridge between you and the authors, distinguished authors of the papers, highlighted papers in the literature. Therefore, please go to the website of Oral Pathology 360 and follow this program. Uh, can we go ahead?
Yes.
Okay, great. Um, Thank you again. Professor Agaimy, do you have any comment on the first part of the article to share with the participants?
Yes, thank you, thank you very much indeed. I am very happy to see this excellent presentation, very clear, very well concepted, and at the same time, maybe I can also say this is in line with a positive evaluation of the paper, because the colleague reflected the data exactly as I have concepted and put them together. So this is a heterogeneous topic that was then put into subgroups. Each of them has a very clear message. So I'm very happy to see this excellent presentation, because as the author, I enjoyed it as well very much, like something new for me. Thank you.
Okay, great. Thank you very much, Professor. Let me start a discussion panel with the general question on the first part. Do you regarding the first part, including the findings and the results, do you recommend us if we encounter an unusual carcinoma in head and neck region, you recommend us to test it molecularly or using NGS to test cytogenetically this unusual head and neck carcinoma to detect, for example, FGFR3 fusions or not?
This is a good point. As we have seen in the presentation, they were put into three subgroups. The group A, or the first group, indeed, is the most interesting subgroup that is in favor of an entity, because all three cases indeed were considered after referral pathology as unclassified. This is the one point. And not only unclassified but suspicious for a driving fusion. So because we have over the years built some experience when to think this is a fusion driven neoplasm, if it does not fit any known entity,
Mhm.
and it is at the same time relatively cytologically monomorphic. When you see bizarre cytological and nuclear atypical mitosis, this is usually very rarely can have a fusion. This is usually is not. So indeed, the cases were tested initially looking for a specific fusion that in some cases was possible mammal 2 like monomorphic mucoepidermoid, or in the one case DEC-AFF2 fusion was the most suspicious fusion because of the background neutrophilic inflammation. So I advocate that point you mentioned, any unclassified carcinoma that does not fit any WHO subtype, and it is not anaplastic or very undifferentiated looking, I would recommend sending it for molecular and usually for a fusion panel. Usually you don't need to look for mutations except secondarily, but primarily it is a fusion topic indeed. You are right.
Great. Great response. Therefore, if we can classify in according to the WHO classification, we can call it, for example, adenoid cystic
Yeah.
carcinoma, mucoepidermoid, or other entities. If it is not, we cannot classify, and it is monomorphic, we can test it for the fusions. How about the third categories you mentioned in your paper? You know, you mentioned, you highlighted the conventional squamous cell carcinoma. I think it's a great challenge for all of us, especially who are are practicing at the hospitals. We commonly see the oral squamous cell carcinoma with foci of creatinization, and we make a definitive diagnosis of a squamous cell carcinoma. How we can microscopically guess that it might be a, for example, FGFR3 fusion associated entity.
This is impossible to suspect because this is a conventional entity that we diagnose a lot of times every day indeed. So I never send them for molecular testing for diagnostic purpose unless, for example, this week I had a case, it was a parotid neoplasm, and they said the patient has definitely no skin carcinoma. In that case, even if it looks like a conventional SCC, but it is very likely primary in the parotid, which we all know that it almost does not exist, I do that. It usually comes negative, of course. But this is the only scenario when I send a conventional looking SCC for fusion testing. Usually I don't do that at all because this is just a question in case that the patient is metastatic and the oncologists are looking blindly for a therapy target, then they submit the case for the molecular tumor board or for sequencing or send it to a company, etc. We see many in-house cases like this just submitted by the oncologist for the molecular tumor board, and usually you don't find more than B53 and some typical SCC mutations, but no fusion. So there is no need and no recommendation to subject any conventional SCC for fusion testing. So category C is a random issue, I assume, or I believe it is not a subject of molecular diagnostic testing.
Okay, great. Thank you. Dr. Suma, do you have any comment or question to share? Additionally, I would like to invite the participant to share their question in chat box, and then we will ask them from Professor Agaimy. Dr. Suma.
Yes, sir. Thank you, sir. Sir, Professor Abbas Agaimy, sir, that's what, as sir said, there were some conventional squamous cell carcinomas, but we also saw that there were two salivary gland tumors as well in the group. So, as oral and maxillofacial pathologists, we do get biopsies from the minor salivary glands, that is, the intraoral salivary glands as well. So, would you recommend that whenever we see an unclassified morphology, even do you think it is feasible to apply these gene fusion study to that as well? Would
Yes,
it
sure.
be?
Yes, for the oral cavity or minor salivary gland entities, again, fortunately, most of them are classified based on the current WHO, either benign or malignant. And if malignant, we have most of them indeed are either polymorphous or mucoepidermoid or adenoid cystic. So if
Hmm.
these three are excluded, you will remain, of course, with secretory carcinoma as the fourth category. Most others are either very rare or unclassified, and I would send them for fusion definitely. Yeah,
Thank you, sir. And also, in the table, we can notice that there was one case, I think the submandibular salivary gland tumor itself, which was HPV negative but positive for P16. So, any messages to be, or how do we interpret that
yeah.
findings?
Of course, we know that P16 is
Hmm.
activated, overexpressed in a plethora of non-HBV associated entities. In other organs, it is usually not an issue because HBV is not a topic. Like, for example, if you look at liposarcomas, leiomyosarcomas, all of them are diffusely strongly B16 positive, but this is a completely different mechanism of overexpression. In a carcinoma of the head and neck, I rely on B16 only based on two prerequisite factors, one of them oropharyngeal location and HBV compatible morphology. If both are fulfilled, then I don't look for HBV, but I am satisfied with B16. And we do not use really a threshold. It is all or none. Either it is 100% positive or not. If it is less than 100% not block type, I send it for HBV subtyping because it is not much reliable. In the salivary gland or in the sinonasal tract, it looks very heterogeneous. I would not rely on that as HBV predictor. Yeah.
Thank you so much. That clarifies a lot of reports that we see as HPV negative but
Yeah.
P16. Thank you so much for
Okay,
that.
can I add something to Dr. Suma's
Please.
question? It was great. Do you commonly start detecting HPV in a specimen using fish or fish study, or at the first step, as you mentioned, that you start with P16 immunohistochemical staining, then you would go to the subtyping of the HPV.
Okay, so it depends. If it is oropharyngeal, we have every day a couple of oropharyngeal biopsies with squamous cell carcinoma, and we always report them as either non-keratinizing HBV compatible oropharyngeal carcinoma, P16 follows, or keratinizing conventional, likely B16 negative or unrelated to HBV. And then if B16 is in line with this primary evaluation, we stop at that level. We don't go further for HBV subtyping because it always will come back as HBV 1618. If it is B16 unexpectedly positive or unexpectedly negative, then
Yes.
we may think of HBV subtyping. And now our practice is that we use a DNA based approach. We do not use in situ hybridization, and it will give you exactly the subtype. Uh, in sinonasal tract, we test all adenoid cystic carcinomas for B16. If it is really block type positive, this is mostly multiphenotypic. We send it also for subtyping anyway because we like to see that if it is HBV 33 or 52, 56, usually it is these rare, unusual serotypes and very rarely 16, 18. If it is a hybrid expression, like the luminal cells similar to CD117 are P16 positive, the myoepithelial mostly negative. So the morphology is very classical adenoid cystic. We don't go for HBV subtyping. We say this is classical adenoid cystic, and B16 is another surrogate for being classical adenoid cystic.
Okay, great. Thank you very much. Do you have any comment, Dr. Suma? Or
And
okay, thank you.
yeah.
And let me wrap up this section of the program with a very basic question, Professor. When you have an undifferentiated carcinoma in head and neck region, could you share an IHC panel for the approaching this undifferentiated carcinoma regarding the after workup the whole body, and we are not thinking about a distant metastasis. Do you have any recommendation for IHC panel to approach these undifferentiated carcinomas?
Yes, for sure. Indeed, again, it depends on the site, if it is oral or sinonasal. It differs, or even salivary. But the minimum, indeed, you have to put in is a low molecular weight keratin marker and SOX10. These are the two very important markers because they help you to recognize poorly differentiated adenoid cystic or salivary type carcinoma versus melanoma. This is the most critical part. If you like to order stepwise, then you can start with very few markers like pankeratin, SOX10. You can add desmin if you think it depends on the cytology exactly. Is it a bizarre looking or very monotonous cell population? Is it basaloid or large cell with very prominent nucleoli, etc.? So based on that, I put very small panel, and usually if it is very monotonous, I add the NUT1 or not M1 antibody. This is a very important immune that is mostly will come back negative, but you pick out, of course, the few not carcinoma cases that are not squamous looking, that are P63 negative. So usually add one keratin, SOX10. If it is not compatible or very anaplastic looking, add the NUT antibody. Of course, you can immediately add cytokeratin 5 or P40. I prefer to use B63 with the risk that you may get a large B cell lymphoma, which is B63 positive, but it is more sensitive than P40. So I very much use B63 critically combined with pankeratin, combined with these two, three markers. So usually you don't need more than 4 to 5 markers. Of course, if these are negative, then you have to go on. And the scenario differs for sinonasal versus non-sinonasal. In the sinonasal tract, any undifferentiated malignancy, I add the NUT, SMARC B1, SMARC A4, SOX10, pankeratin. These are the 5 markers I use. If they are not helpful, then you expand your profile.
Great. Very informative and practical, Professor. Thank you very much.
Thank you.
And Dr. Mandana, we are ready to go ahead with the next videos.
Yes, here it is.
Moving on to the discussion, FGFR gene fusions occur in three oncogenic settings which work as the main cancer driver, act as helper drivers along with other changes, and also cause resistance to cancer drugs that are tyrosine kinase inhibitors. Few examples of this gene fusion have been recently reported in non-epithelial carcinomas, that are FGFR1 TACC1 is seen in rhabdomyosarcoma, and FGFR2 TACC2 is linked to drug resistance in GIST, and FGFR3 TACC3, which is most common fusion, is found in brain, bladder, head and neck, lung and cervical cancers. As these gene fusions are gaining lot of clinical importance because they are associated with resistance and potentially targetable by therapy. Authors have been observed that FGFR3 TACC3 fusions are found in different variations in different cancer types in different organs. There could be a correlation between this gene fusion and microscopic appearance of these tumors. The authors have pointed out that no studies so far have been examined where such connection exists. Several studies have been reported that tumors with these gene fusions have a phenotype of squamous cell carcinoma or urothelial carcinoma with squamous-like morphology. Similar reports from ovary and lung adenocarcinoma were also reported. Together taken, the literature says FGFR3 TACC3 tumor had similar features to transitional cell-like morphology or similar to squamous cell carcinoma or a mix of both. Majority of the cases in the current study also showed similar findings. In head and neck carcinomas, this gene fusions was studied in 22 cases in various studies involving nose, nasopharynx, oropharynx, parotid and others, of which some cases were HPV positive. This is the summary of reports of FGFR3 TACC3 fusion in head and neck carcinomas. Majority of the cases, except those highlighted with red, the SCC diagnosis was not available. That is, whether the diagnosis was based on the morphology or immunohistochemical staining found as blind screening. As this study is first of its kind, no previous studies have been examined the morphologic characteristics of head and neck carcinomas with this gene fusion. As discussed in the results, the authors could categorize 9 cases into 3 groups. The first is conventional SCC, the second HPV associated cancers, and the third was unclassified HPV negative cancers. The first group, that is conventional SCC, involved 2 cases. Here, the fusion appears to be random and there was no morphological hints related to the fusion seen. The second group was HPV-associated sinonasal carcinomas involving 3 cases which showed heterogeneous morphology, and the HPV subtype for respective cases was classified as follows. HPV-33 was associated with multiphenotypic sinonasal carcinoma, which was recently described as a distinct entity. Non-HPV-16 or non-HPV-18 shows salivary-like growth patterns. And the second was HPV-18, which was associated with high-grade unclassified morphology with solid undifferentiated growth pattern, and undetermined high-risk HPV was associated with mucinous adenocarcinoma. FGFR pathway activation plays vital role in HPV-associated carcinogenesis in cervical cancers. Other studies have also reported role of these gene fusions as an important event HPV-related carcinogenesis. UBR5 and ZNF423 and FGFR3 and TACC3 fusions are detected in nasopharyngeal carcinomas, which are also virus-induced. And the fusion also detected in one HPV-positive oropharyngeal carcinoma. These points make this gene fusion as a central oncogenic role in viral-induced carcinomas, which is not a random event. And the third group was unclassified head and neck carcinomas, in which all the cases were HPV negative and the tumors could not be classified by histology alone. Next generation sequencing was carried out for diagnostic purposes. This category showed overlapping features with TEK-AFF2 sinonasal carcinomas, including transitional cell-like morphology, uniform cells, squamous immunophenotype, and prominent intratumoral inflammation. However, the type of inflammatory cells and the growth pattern were different. And it also showed prominent inflammation which showed mononuclear cells and seen in the stroma as well as within tumor cell aggregates. The activated FGFR3 MAPK signaling might be the cause for the inflammatory response. In addition to FGFR3 TACC3 mutation, one case involving salivary gland tumor showed additional driver alterations of BRCA2 and PTEN, which was initially diagnosed as salivary duct carcinoma X pleomorphic adenoma. And this pleomorphic adenoma not seen histologically, and gene fusions related to pleomorphic adenoma were not seen. Genetic changes showed no breakpoint variants in all cases, and the FGFR3 gene joins with the TACC3 gene. The fusion retains FGFR3 as an active part and TACC3 as a binding part and causes abnormal cell division leading to development of cancer. This transformed acidic coiled coil maintains mitotic spindle stability. Thus, any abnormalities in TACC leads to aneuploidy, chromosomal aggregation errors, and cancer progression. These FGFR fusions can be treated with FGFR inhibitors, which makes them as a therapeutic targets even if other driver alterations are present. And they can make tumors resistant to anti-epidermal growth factor receptor drugs in head and neck cancers also. They also show strong diffuse FGFR3 staining on immunohistochemistry may help detect these tumors. To conclude, thus, FGFR3 TACC3 fusion tumors are heterogeneous type, which is an important subset, and they indicate a new carcinoma subtype. They are very crucial for diagnosis and therapy, and more studies are needed in this gene fusion. As a note on future studies on this gene fusion, more research is needed to confirm their role as a distinct tumor entity and clarify their prognostic behavior. They also create approaches for molecular diagnosis and targeted FGFR based therapies in head and neck cancers. Thank you, everyone. It was indeed a great honor and my privilege to present this journal article today at international level. I would like to express my heartfelt gratitude to our respected dignitaries, Dr. Mandana ma'am, Dr. Pouyan sir, the author of the present study, Dr. Abbas Agaimy sir, and Dr. Suma ma'am, for the continuous guidance, support, encouragement, and giving me this opportunity to participate in this academic forum. My sincere thanks to esteemed faculty members and professors for giving their valuable insights and motivation for shaping my understanding. I also thank the online streaming spectators of this journal club presentation. At last, I thank the organizing committee of Oral Pathology 360 for providing me such a platform to share knowledge and gain international exposure. Thank you all.
Thank you very much.
Thank you, Dr. Yashwant, for your nice presentation. Professor Agaimy, do you have any comments or uh, additional comments, in fact, to the second part of the presentation?
Thank you very much again. Very brilliant, very clear presentation of the data, more clear than our paper maybe. I think the paper has as a main message that when we see some heterogeneity in some tumors sharing a genotype, we have to break them down to see, to look inside, not just to, that sometimes you send such a series to a journal, a reviewer may say, no, this is too heterogeneous, no one can understand that, just reject it. So this is not the scientific approach. As we have seen, we have three subgroups. Each one of them has very distinctive inherent peculiarities. Even in the cases of multiphenotypic sinonasal carcinomas, an additional fusion which is similar still need to be addressed in an oncological context if this fusion really carries a clear therapeutic value, which is very possible based on very rare or simple observations. I like just to add one point regarding the salivary case, which indeed was very peculiar because the slide and the images of that case show there is a focal nodular sclerosis that was not definitely clearly recognizable as pre-existent pleomorphic adenoma. So it is a very difficult case. The invasive component with this extensive inflammation is very unusual for classical salivary duct carcinoma. We know that salivary duct carcinoma may sometimes have a poorly cohesive pattern associated with inflammation, but it does not show this morphology that we just have seen. And this extensive inflammation is frequently reflection of some underlying peculiar genotype in that case. I have seen a couple of additional cases, mostly from the parotid gland, and my impression is that it might be that not always FGFR3, but even FGFR1 or 2 may be enriched among salivary duct carcinomas that tend to show more squamoid or basal-like differentiation. So I think this is just a beginning of that line. We expect to see more in the literature on that topic. So it is not just a single case, I assume, but it is an index case that may show a specific pattern in future cases. Unfortunately, many of these reflected literature data were mostly oncological series. So they will tell you, yes, it is a salivary duct carcinoma, but you don't know exactly how it looked alike morphologically. And they mention the fusion. So we pathologists have the task of looking at the morphology of these cases to see even those cases called squamous cell carcinoma in larger oncological series, are they just called squamous because of P40 or are they morphologically squamous? So really there are many issues that are, I think, related to the conclusion of this study that we can expand on in the future.
Okay, great. I lost a few seconds of your presentation, of your explanation. However, thank you very much, Professor. Let me highlight a part of your explanation about the inflammation in background of the tumor. You mean that when we are making a definitive diagnosis, we should pay attention to the background stromal inflammation. You know, when I am reviewing microscopic slides, and I sometimes don't pay attention to the stromal inflammation just for grading, for example, squamous cell carcinoma regarding the Brine grading system. Otherwise, I don't pay attention to this. You mean that you recommend us the meticulously evaluate the stromal inflammation and thinking about the association between this inflammation and the probable fusion in the entity. Is it correct?
Yes, this is correct. Of course, the stroma is always or frequently ignored. The stromal characteristic, is it fibrous or myxoid, vascular or avascular, inflamed or not? And if it is inflamed, is it mononuclear or neutrophilic? And is the inflammation also intraepithelial or just stromal? All these factors are very relevant. And I think really we recently have observed as a very striking example the deck carcinomas in the sinonasal tract. These tumors are so characteristic, they have too much very extensive neutrophilic stromal and intraepithelial reaction that is almost enough to recognize them on H and E stain slides without molecular. So if they look like that, they always have that fusion, if you send them or not. So I think it's very important to look at this. And in conventional carcinomas that not are very suspicious for a fusion, when they are too much inflamed, we know that these have very now emerging prognostic and therapeutic relevance with immune therapies, and even the prognosis is different for those so-called cold versus hot neoplasm. So this is important point always to mention.
Okay, thank you very much. And one question, and afterward, I will ask Dr. Suma. Is the anti-FGFR tyrosine kinase inhibitors drug accessible commercially for the patients around the world or not?
As far as I know, there are many FGFR inhibitors on the market. They are definitely commercially available. The indication is always, of course, is the issue, because for many entities like urothelial carcinoma, where they are most frequent, there are, of course, certain levels of stratified oncological therapy. So they will go for the first line, the second, and as until now, the main principles of oncological practice is to exploit all standard therapies, and if you are done, then you are close to these tyrosine kinase inhibitors. But for each entity, there is a different, of course, approach or guidelines or recommendations, but they are definitely are available commercially.
Yes, exactly. And I would like to highlight again the importance of your paper, because you present, you introduce a very important targetable treatment for this entity. And I would like to invite again all participants to review and read this paper meticulously. Okay, Dr. Suma, do you have any comment or question to share with Professor Abbas? Please unmute.
Yeah, I think you're on mute. Yeah.
Okay, sorry about that. I think thank you, sir, for this. Very insightful paper, because even though the main message talks about we are talking about a new entity, there is also so many sub messages in it. Like one, Dr. Puyansa mentioned, one is the targetable by therapy. There's also the HPV association and why FGFR would lead to the viral carcinogenesis. And you have mentioned that it's not a random event, it's playing a central role, that this receptor. And also you've mentioned future outlook is also there, where we can go ahead and look for more of these fusions, because we it is whenever we see a textbook, FGFR3 fusions are always with urothelial carcinomas, this kind of fusion. But when we relate it to head and neck carcinomas, this was completely new.
Yeah.
And thank you so much for that, sir. And if I have to ask, what is your can you summarize your experience with other FGFR fusions, if you have come across relevance to head and neck? Because I know I saw and you've published more than 700 papers, so maybe it's
Yeah.
difficult, but
We indeed, on this exact FGFR fusions, I have not published a lot, but we have many cases in files, and it seems that I think really, I always like to recite one sentence used to be said always by Dr. Rosai, who said that there is no gene that deserves its name, and alteration of that gene would not result in a morphological shift or phenomenon. So any gene involved in a true genetic event, usually it reflects its nature in one or another way. And in this particular topic, it is very striking that these FGFR fusions are very frequently linked to a transitional cell-like morphology. So even the case of the multiphenotypic that was used in figure 2 in the publication, it has very remarkable transitional cell-like morphology, and not the very classical adenoid cystic-like everywhere, but it has multiple patterns. And recently there was also some reports that even for those doing GYN, the so-called malignant brain tumor in the ovary, which is a transitional cell type carcinoma, it also has FGFR3 fusions. So it means when we see, we have to come a bit away from the vague definition of squamous. Squamous immunophenotype does not mean squamous cell carcinoma. So
Great.
I like to see the classical squamous cell morphology at cellular and architectural pattern and keratinization. But if it is absent, but still I see P40 or B63, I have to exclude all molecular subtypes, including nut carcinoma, DEC carcinomas, FGFR3 carcinomas, and even adamantinoma like Ewing sarcomas. All these entities are defined molecularly, but they are by immunoclassical squamous. So this is, I think, one of the also important messages. At the end, we put three sub messages. One is for oncology in general, that you have squamous cell carcinoma aggressive, you are looking for targets. You should not look only for mutation but also for fusions, tyrosine kinase fusions. You have multiphenotypic sinonasal carcinoma. You should not, or you don't need not need to do fusion testing, but it is very interesting and promising to look at the frequency of fusion in these tumors, which are driven primarily by these HBVs. And the third one is this possible entity or category of FGFR3, TACC3 fusion carcinoma that looks like DEC or mucoepidermoid, so it looks like unclassified epidermoid or squamoid carcinoma. If we look at all these points at the end, I think we have a good take home message.
Thank you so much, sir. Sir, in your experience, have you found any different pattern in the clinical outcome wherever there are FGFR3 fusions compared to those other malignancies?
Of course, to address that, you need a larger case series, that you have enough cases in each subcategory. The squamous cell carcinoma, the classical, is aggressive as always. The one case from the parotid that came like DEC fusion carcinoma was clinically also very aggressive. For some of the cases, we don't have enough indeed follow-up data. So we have to await more cases to be reported and long follow-up, of course, and then we can address any prognostic distinctnesses and any difference in responsiveness to standard chemotherapy, because we know that fusion associated malignancies usually do not respond to standard chemotherapy, and they need different types of therapies, like not carcinoma, for example. They don't respond to very classical chemotherapy as well. So this is, I think, very mature to tell now we can address that point.
Thank you so much once again, sir, for this new message, new point of correlating morphology with fusions. Thank you so much.
Yes, thank
Thank
you.
you very much. We have about 2 minutes to wrap up the meeting. Let me share a few quick questions, Professor. Personal, I would like to share your personal experience with me because we have some issues with the routine practice of immunohistochemical staining of the head and neck carcinomas, and I would like to know your experience. What do you think about the do you rely on androgen receptor to make a definite diagnosis of salivary duct carcinoma of the major salivary glands, or you prefer to have an extensive panel to make a definitive diagnosis?
Yeah, this is of course a very good point and very critical issue in subtyping. I usually use or rely indeed on androgen receptor to call something in the major salivary gland salivary duct carcinoma. But before seeing androgen receptor, I should have, must be convinced this is a tumor in the spectrum of either salivary duct or high grade adenocarcinoma NOS. If it fits that category, then for me, androgen receptor is enough to call it salivary duct carcinoma. I don't like to see the very classical salivary duct carcinoma pattern as some people used earlier. Now, all people, or most of them correctly, do agree that if it is a high grade adenocarcinoma, not otherwise classified androgen receptor positive, this is the spectrum of salivary duct carcinoma. But we know that, for example, very recently described entity, the so-called palisading adenocarcinoma described by Dr. Bishop, that is a solid pattern carcinoma, mostly in the sublingual gland. It is 100% androgen receptor positive. and it is not a
Mm,
salivary duct. This means, and it does not look apocrine indeed. So the only receptor is not enough. I like to see the morphological context as a basis, and if it is, then androgen receptor is enough to call it salivary duct carcinoma. If it is, but the receptor is negative and everything other is excluded, I still use the term androgen receptor poor salivary duct carcinoma, but these are mostly basally differentiated. They have some squamoid morphological and immune features indeed as well. So that is
okay,
my approach with regard to
great.
AS.
Perfect. Thank you very much. The last, but not the least, a very personal question to detect myoepithelial cell in salivary gland tumors. Which marker do you recommend? Do you rely on P63 or P40, or you prefer a combination of several markers to detect, especially in for example, adenoid carcinoma, to differentiate adenoid carcinoma from other carcinomas, especially polymorphous adenocarcinoma. How do you detect myoepithelial cell?
I think my most reliable mark is the H&E. So
Oh, great.
if it is not really helpful or much helpful, then it depends on the context. So if it is polymorphous versus adenoid cystic, a small biopsy, you can rely on positive B63, negative B40, of course. This is one of the good issues. Otherwise, calbonin, SMA, all these markers should be used really in combination. I don't see any single reliable myoepithelial marker in these cases. If it is the issue of myoepithelial carcinoma, then I think the morphology is the best marker than any combination of markers, because they
Great.
usually are very distinctive cytologically, and the architectural pattern and overall is very helpful. Because, for example, I know that some of my colleagues, they diagnose many basal cell adenocarcinomas as myoepithelial if they look at immuno, because they overlap, of course, but the morphology is very distinctive. So I rely much on the H&E.
Thank you very much. I would like to sincerely appreciate your contribution, Professor Agaimy, and also I would like to thank Dr. Suma for sharing your time and knowledge with us, and Dr. Yashwan, thank you very much. And here is the certificate of appreciation, Professor Abbas. You always generously share your experience with me and today with the participants, and it's very kind of you.
Yeah, thank you very much indeed. It is really a true pleasure and great honor to participate for the first time in this very prestigious and very interesting concept. This journal club I have not attended before, but it is very much enjoyable, and I have to say I will be trying to attend the future rounds very likely. And thank you very much to all of you, of course, for your for the presentation, for the discussion, of course, the introduction, and for the attendees, of course, as well. Thank you very much.
You're welcome. Our pleasure. And thank you very much, Dr. Suma, for
Thank you.
being with us. It was very great contribution. Thank you very
Thank,
much.
thank you so much. Thank you for the opportunity.
And also Dr. Yashwant, great presentations. It was very great, and thank you for covering all of details of the paper in your presentations.
Thank you so much, sir. It was my pleasure. As it was a great article, just I have been just presented that.
Our pleasure. And Dr. Mandana, thank you again for providing such a great opportunity for us to be in touch with our colleagues and the distinguished authors. Thank you, Dr. Mandana.
Thank you so much. It is truly my pleasure to have everyone here. I must say, this journal club with the authors is really Dr. Pouyan's baby. He is the one who has conceived, and he is doing it so perfectly. It's really very nice. And today I was very happy to have, of course, Professor Agaimy with us. Thank you, sir, for joining us. And thank you, Dr. Suma. Thank you, Dr. Yashwant. And thank you, everyone who has attended. Uh, it's been wonderful. It's and Just before we go off, if you have joined late, or you have missed part of the discussion, or you want to watch it again, basically it will stay available on this same link forever on YouTube. You can watch it anytime you want. And if you're a channel member and you would like to get your certificate, well, the link is there in the discussions in the channel posts. If there's any problem, get in touch with me. And yes, that's about it. I would like to say thank you again to everybody. And I would see you all again next time. Stay curious, keep learning, and we will see you next time on Oral Pathology 360.
Thank you.
Thank you.
Bye
Thank you
bye.
very much. Thank you. Thank you.
Thank you.